Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I'm really excited to have on the podcast Dr. Vanna Zanagnolo and Dr. Lucia Ribero from the European Institute of Oncology, Division of Gynecologic Oncology in Milan, Italy. And the reason for this podcast is, of course, our May lead article and it's titled Single-Port Robotic Surgery in Gynecologic Oncology, Feasibility and Safety After 1 year of Implementation. Vanna, Lucia, thank you so much for joining and thank you for accepting our invitation to speak about this article. I'm really excited to hear some more details, of course, obviously, on this very interesting topic.
Thank you for the
Thank you.
invitation.
Thank you very much. It's been an honor to be here with you.
Excellent. So we have lots of questions, and of course, many of those questions are coming from our fellows in the journal. So hopefully, we'll be able to get through all of them. So I'll start with you, Vanna. Let's kind of set the stage as it pertains to how single-port, minimally invasive surgery came to current standard practice, first in laparoscopy, and now more recently in robotic surgery.
Okay, in fact, it's a long story and not always successful, but it started with the single site laparoscopy, which has been not really very successful. It was very, very difficult with a very long learning curve, and mainly because there was a completely loss of triangulation of the instrument, and there is some people are still doing the single site laparoscopy. There's a lot of clashing of the instrument, and so the surgery is really, really difficult. It's never a very smooth surgery. And then the Da Vinci single site came along, and that was a little bit of improvement. There was a little bit of a better triangulation of the instrument inside the abdomen, but the instrument were not articulated, and there are still a lot of collision between the instruments, and therefore again not so useful in terms of performing more complex procedure. Maybe a simple procedure were okay, but not very complex procedure. And then eventually in 2024, that was approved in Europe, the single-port, Da Vinci single-port, and that's really is a dramatic difference compared to the other two approaches, mainly because we have a 360-degree access to all four quadrants through a central fulcrum, and you can move from one quadrant to the other without redocking, and that's of course with the instrument where you can have triangulation, and that prevent a lot of collision between the instrument, and it allows you to perform a lot of most of a procedure that usually you can perform with the multiple port. And sometimes the reason you're not able to perform the procedure with the single port because there is still lack of some instrumentation. And actually recently they provided us with new instrument with a wider range of motion. So our surgical field, the diameter of our surgical field, which was one of the limitation, moved from 7 centimeter to 12 centimeter, improving also from that point of view. So we are really in a much better place than when we started with the single site laparoscopy.
Excellent. Thank you so much, Vanna, for like that very broad overview and put in perspective so well. My next question is actually with the introduction of the Single-Port Robotic Surgery platform at your institution. As you know, when there are discussions about introducing single-port, often from either institutional leadership or from other surgeons, the response is, well, what is it going to be able to do that we can't already do with the standard robotic platform? So why do we need to get another robot? Why do we need to put the expenses and the cost into this? How was it the introduction in your institution?
Actually, it was interesting because first of all, we have 5 subspecialty which use the robot. So we have 3 platform, multiple port plus one single port, and the robot are used 12 hours a day for 6 days. So, and that's the best way to be able to cover the expenses, to be able to come even, and maybe also not to lose money at all. So the instrument was first introduced by the urologists who really wanted the instrument. At that point, we always especially wanted to use it. And of course, we really didn't know what would be the difference, whether there was a role, but we started to use it, and we thought that there could be a place in a sense that it is not going to replace the multiple port, but it can have some different indication, even though now we are realizing that some of the procedure where we thought we were going to be able to do only with the multiple ports, such as the staging of early stage ovarian cancer with the changing of the from the lower quadrant to the upper quadrant, performing the pelvic and periaortic hysterectomy, which seems like a little bit complex, but now we are able to do it with the single port, and in that case, for instance, is much more convenient in terms of timing. For we don't have to do the redocking, and so is kind of more efficient. It could be more efficient with a multiple port. But anyway, at the beginning, we started because the urology wanted it, and also we found we had the instrument, and we said we want to try it. So at the beginning, we really didn't know what we would be able to do with the new platform.
Yeah, and of course, obviously, with regards to the indications, and it's been reported for general gynecology uses, as you mentioned, for other specialties as well. Within gynecologic oncology, particularly in your institution, I would presume for cancer cases, this is primarily for endometrial cancer, or you also mentioned ovary as well?
No, no, no. In fact, actually, the reason we have most of our cases, or at least 50% of our cases, are endometrial cancer, is because we have a lot of endometrial cancer cases, and we most of the cases are performed using a robot. We very rarely use single standard laparoscopy. So sometimes it was related to the waiting list. It was related to the fact that the system was available. So it was not thought for endometrial cancer itself. And actually, we, as I mentioned, we have been using it for ovarian cancer in early staging for ovarian cancer. And one indication where we think is really could be really very useful is the case of recurrence of ovarian cancer in case we have a single or very few recurrences. Like, for instance, if we have, like we sometimes had a small nodule in the pelvis and then a small nodule in the upper quadrant. Like, for instance, we perform the splenectomy in one case and then shed another nodule in the other quadrant, and we move. And so we've done more than 10 cases where in patients who had already received surgery, so patients who can be difficult in terms of a new minimal invasive approach, we were able to perform all these cases using a single port, having such a small incision, and being able to remove very well the recurrence. And that's not only when there was not only a small nodule, which of course it could be done even with the laparoscopy, but even in case where we had like a lateral pelvic side wall recurrence, diaphragmatic recurrence, as I mentioned before, splenic small nodule on the spleen, which needed the splenectomy. So I think that could be a very useful indication, because sometimes especially if you have more than one location and in different quadrants, the multiport can be not as easy to use, and as I mean, it can require more time to redock, to move the patient to. So I think that can be one good indication for a single port in gynecology oncology.
Excellent. Yes, and we're going to get into some of the indication questions as well a little bit later. I'll turn over to Lucia. Lucia, tell us about this study. What was the design? What was the objective? And what was your inclusion criteria?
Okay, this was a prospective core study conducted at the European Institute of Oncology in Milan between July 2024 and June 2025. The objective was evaluate the feasibility and safety of single-port robotic surgery in gynecological oncology. By feasibility, we meant the ability to complete the planned procedure entirely through the single-port robotic platform without conversion to a multi-port robotic system or to open surgery, and without the need to additional ports. And by safety, we measure outcomes that include intraoperative occurrence or events, complications, postoperative complications within 30 days, and hospital readmissions. So, by indications, our inclusion criteria were all patients with suspect or confirmed gynecologic malignancy, either primary or recurrent, endometrial, ovarian, or cervical cancer, conservative, or also fertility sparing, and as well risk reducing surgery for hereditary cancer syndromes.
Excellent. So, 63 patients, of course, obviously an initial experience description included in this study. What are the highlights? What are some of the things that you would want to point out as the main takeaway points from this study?
Yes, we included 63 patients with a median age of 57 years and a median BMI of 24.4. 49% had a prior abdominal surgery, and the most frequent surgical indication was endometrial carcinoma in 47.6%. And the single-port approach was feasible in all patients with no conversions to multi-port and open surgery and no need for additional ports. There were not intraoperative complications as well, and the surgical time was 131 minutes, and the postoperative pain was very low, with a median numerical rating scale score of 1 at all assessed time points. And for the postoperative complication rate, it was 17.5% overall. And for the major complication, classified as clavendin grade 3B, occurring in 4.8% of patients. These major events were pelvic lesions managed with minimally invasive drainage for the 3 cases.
Excellent. So thank you for that.
So we demonstrate. Sorry.
No, I'm sorry. You had another statement.
Yes.
Oh.
Yeah, that was feasible, and there was a safety profile.
Okay, great. I want to actually get into some of the questions from the fellows. And this one, I'll turn to you, Vanna, from Beate Sarta from Latvia. And she's actually asking, how are you currently selecting patients for single-port surgery? Which cases do you think should still undergo conventional robotic surgery?
Okay, we try really not to select too much, and that was true for sure for the first 20 cases, which we consider the learning curve, where we try to choose not overweight patients, uterus which were not big, and situation where we knew that we wouldn't have too many problems to face, and because we wanted to test the new system. But now, as I mentioned, most of the limitation, most of the selection is related to the waiting list and to the availability of the platform. But for sure, there are some cases like the very obese patient that I think they still require multi-port. And the reason is because even though we are having a better triangulation with this new instrument where there is a wider extension of emotion, which wide the surgical field, still there is some limitation in how much you can lift with your instrument, because the instruments are slightly smaller than the one used for the multi-port. So if you're dealing with a very big patient, very obese patient, sometimes that can be a limitation. So we usually select the very obese patient for a multi-port. But whereas as I mentioned before, we select on the other way, and we select those patients who need surgery for recurrence patient. We select those for a single port because we believe that is for sure a very good indication.
Okay.
Also because, for instance, sorry, I didn't want to interrupt you. For instance, with the camera mode, which is called Cobra, where you can really switch from different angulation of a camera. For instance, if you have a lesion or you have to work on the abdominal wall, is absolutely very easy, much easier than one with the multiple port. And sometimes we had a recurrence which was really at the anterior abdominal wall, and using the Cobra mode, the surgery was really very easy. So
Excellent. Vanna, I'll stay with you. And this question comes from Vincenzo Tarantino from Agostino Gemelli in Rome. And he's asking, after the first year of experience, do you feel Single-Port has a true clinical niche in gynecologic oncology, or is it still mainly a technical evolution of what we already do with conventional minimally invasive surgery? In other words, in which patients or procedure do you really believe that there's a genuine change in practice potential?
okay, of course, with all always with the introduction of new technology, there are a lot of doubt about whether we really need this new technology with new platform. And it's true that with the multiple port, you can do everything. It's very easy. The ergonomic is excellent. Why should we change? And I believe that we should keep exploring, because this new platform at the beginning I thought, okay, it's fun for surgeon. Maybe the patient is happy because she's gonna have this very small incision. But then you realize that for also what you would think is a limitation, the fact that you have a small surgical field, sometimes it can be an advantage because you can really work in very small areas, and it's like a change of philosophy, because it's not that you have a limitation. You only need to concentrate in the small field and then move to the other one. And it's not a big deal. It's the moving of all the instrument is very fast. And so in the fact that also you don't have to be concerned about the assistant, because you don't have you have some assistant but very little, and also you can move all around the four quadrant, and that is very, very important. And I think that I cannot say I'm sure it's gonna be something that is going to change completely the way we treat our patient, but I think we need to keep trying and to try to implement this new platform, because I believe that is going to be very useful in the future.
Great. Turning over to Lucia, this question is actually from Nicole Chris at University of Western Australia. And she's asking, postoperative pain scores were very low in your cohort. Can you tell us what you do routinely in your unit to manage wound and gas pneumoperitoneum-related pain in these patients?
Thank you for this question. Two aspects. The first, for the pain management, we use the protocol is a combination of acetaminophen and non-steroidal anti-inflammatory medication, just that. And for the pneumoperitoneum-related pain, We use the system, the air seal system, to ensure the stable intra-abdominal pressure throughout the procedure and maintain the insufflation pressure at 10 millimeters of mercury. And then we perform a slow control exsufflation at the end of the surgery. So maybe likely this system contribute to the very low pain of the
Excellent.
patients.
So Lucia, also with you, this question comes from Naya Seminario, from Vallebrón Hospital in Spain. And she's asking, did you find differences regarding time for completion of surgery? We already talked about postoperative pain, complications when compared to regular robotic surgery or laparoscopic surgery.
Yes, this was not the purpose of this study, so we cannot answer this question. Our study was a prospective cohort with a single cohort in focusing in feasibility and safety in single-port robotic surgery. So direct comparative studies are needed to answer better these questions.
Yeah. And as a follow-up to that, actually, for either of you, and since we're talking about perioperative outcomes, the median hospital stay was 2 days. And as you know, obviously, in the United States, most patients go home the same day. So traditional robotic surgery, traditional laparoscopic surgery. So there might be some who might say, why should I start doing single port when it actually keeps the patients in longer in the hospital versus my outpatient procedure? Well,
No, you are absolutely right. The problem is a reimbursement policy in Italy. You need to keep oncology patient at least today, otherwise you don't get your reimbursement. So in fact, it's funny because the patient want to go home, and we could say, no, it's better if we stay another day. We want to make sure you're doing well, because they don't understand why we have to stay. So I hope we are trying to get some improvement in that terms, because otherwise it's really funny, because we are going to get less reimbursement if we discharge the patient the same day or one day after surgery. So that's, in fact, it doesn't make any sense with 2 days, because it's always 2 days, because the patient cannot go home earlier.
okay. Yeah.
So it's funny, because a private patient who pay for the surgery, or who has insurance, they can go home earlier. But
Mhm.
the patient who are under the social governative system, they have to stay 2 days.
Yeah, very
So
well.
that value doesn't mean anything. Exactly.
So it's science hindered by policy.
Yes, absolutely, absolutely.
So Vanna, this question comes from Giuseppe Parisi, also at Gemelli Hospital, and he's asking, considering that the study included all consecutive single port cases, but not all consecutive minimally invasive cases, to what extent do you think patient selection may have contributed to these really very favorable outcomes?
Okay, for sure, as I mentioned, the first 20 cases were absolutely selected for a single port as simple cases with easy patient, with perfect patient, thin and everything. But then, as I mentioned, the following 43 patients were selected based on the list, on the waiting list, and on the availability of the platform. So in this, I cannot say that there was really a significant selection bias, beside the fact that, of course, the really obese patient were selected for the multiple port, but otherwise there was not a real selection based only on the fact that we are going to do the surgery using the new platform.
Excellent. Lucia, turning to you, Albert Matthew from here, actually, Houston Methodist, one of our residents. He was asking about complications and said, for the complications listed in the article, were there any specific procedures that had increased rates of complications, or even perhaps as you have had this experience, both you and Vanna, are there any patients that you might say, nah, definitely not single port because I can see how this could potentially lead to higher complication rates?
Yeah, it's difficult to draw meaningful conclusions about complication rates by procedure type because the cohort is too small. We have just three major complications. Just going through these three, the patient had hysterectomy. So we can see this relation. But then I think we need to go a little bit forward to see the safety of this approach to better define the complication rates by procedure. So no, I don't know if Vanna wants to add something to this question.
Yes, in fact, no, I agree with what you said, that we cannot really say much about what was the reason for the complication. For sure, since they were mainly either pelvic collection or abscesses, that of course related to a situation where the bleeding can be more, and of course hysterectomy is a procedure that can have some bleeding, and so, of course, the more complex it is the surgery, the higher the chance of having a complication. But there is nothing that we can really say based on this data. And of course, we are going to need a longer follow-up for some of the complications that has been listed for a single site, for instance, single site approach, meaning the risk of umbilical hernia. That can be a complication, but of course not after 30 days. So it takes longer to really be able to confirm whether this can be can have an increase of such a complication.
Excellent. So, Vanna, this next question is asking about patient desires for this approach. The question is, given that single port incisions are larger than individual port sites, multi-port sites, do you believe that the quote cosmetic advantage of a single scar, number one, carries an inherently higher risk of long-term incisional hernia that we simply haven't yet really learned because of a short follow-up? And then I think as a follow-up to that, as a second one, and this brings me back to when we were doing the first cases of single port, that do we really have a sense that patients really care whether they have one incision or three or four tiny little incisions, particularly these patients with endometrial cancer and patients that often are, certainly focusing on the oncologic outcome rather than the cosmetic outcome?
Now, that for sure is a comment that I used to make, saying if I'm going to ask to my 75-year-old obese endometrial cancer patient, she's going to laugh, say, who cares? I agree. But on the other hand, we still have to realize whether it's true that a small, a little bit bigger incision is the same as having 4 or 5 small incision. And that's, of course, we need the data, we need the study which would compare the two situations. But in terms of aesthetic result, these are actually pretty good, because you think that you have a 2.5 to 3 centimeter incision, which is in the umbilicus. So what you're going to see is really like few millimeter of a scar when you see the patient after 3 months. And in the paper, we show the difference of a scar at the day of the surgery after 30 days and then after 90 days. And you don't even see the incision. And of course, if you have a young patient who maybe you're going to perform surgery for cervical cancer. Of course, now we are performing radical hysterectomy or anyway minimally invasive approach only in patient with early cervical cancer after conization with negative margin. because of your study. But in May, we're going to get the result of a RAC study, and hopefully maybe things are going to change, and we may be able to go back to performing minimal invasive approach for the treatment of early cervical cancer patient. And most of them are younger, so much younger than the endometrial cancer patient. And in this case, maybe the aesthetic aspect of this approach can have a different value. In fact, for instance, when we perform some procedure for fertility saving procedure young patient, for sure these patients are happy that we are telling them we're going to do the procedure with a single pore, you're going to have only small incision, and of course they can appreciate more this aspect, even though I agree that for our patients, which are more concerned about their disease, the fact of having a small incision of 4 or 5, a little bit smaller incisions doesn't make maybe a big difference.
Excellent. So, Vanna, as a tradition now in the podcast, the last question. So, the question is formulated by AI, and it's a question regarding, of course, obviously the AI interpretation of your study. The question is, given that your primary endpoint is feasibility, so 100% completion, no conversions, how do you justify any clinical adoption of this technique without oncologic endpoints, particularly margin status, nodal yield, recurrence patterns, survival, especially in diseases like cervical cancer or ovarian cancer, where surgical radicality is outcome critical?
Okay, it's an interesting question, but of course we started with the feasibility because of course if it wasn't feasible we wouldn't go on to do anything else. But of course the next steps are related to all these different aspects which need to be evaluated. And of course, talking about cervical cancer, I already mentioned the fact that in terms of how you perform a procedure, there's not a big difference between multiple port and single port. So we are not expecting to. And of course, in cervical cancer, we still need to know whether we can go back to minimal invasive approach. But I'm not expecting to see a higher incidence of positive margin or something like that. For ovarian cancer, again, we right now don't use really minimal invasive approach for advanced ovarian cancer until we see the result of a lung study showing that there's not going to be a difference in terms of oncology outcome. So for sure, what we will do, continuing with our prospective study, is to confirm that there is no difference in terms of oncology outcomes for patients where already the minimal invasive approach has been shown to be not inferior to the traditional open or laparoscopic approach.
Excellent. So thank you both. Really enjoyed this discussion. Congratulations on obviously initiating this technique and this approach at your institution. We look forward to future reports on this patient population. And once again, of course, obviously, thank you for sending the manuscript to our journal and for your time in this podcast. Definitely looking forward to the journal club on this particular article as well later in the month in May. Thank you.
Thank you very much. It was very nice to be here with you and seeing friends all around.
Thank you so much for the invitation, and see you later this month.